Okay, so to continue, we have part two, no, of this week's topic. So that's antimicrobial susceptibility testing. Okay, so the learning outcomes for this particular topic is that at the end, no, the students should be able to explain the rationale between behind rather the performance of antimicrobial susceptibility testing, no, why we need to perform this. Okay, what's the significance of doing or finding out MICs, MBCs, no, MICs, MBCs, to learn how to record or no, report zones of inhibition, okay, and of course to explain no, the meaning of uh, susceptible, intermediate, and resistant. Okay, so antibiotics are chemical substances. No, this may be synthesized or naturally acquired. No, these are chemicals that are able to kill microbes, other than those that from which they were extracted from. Okay, so natural drugs, they are extracted from fungi or bacteria. Okay? Examples, you have your amphotericin, your erythromycin, okay? And then you have synthetic drugs. Okay? These are chemically produced drugs, no? Meaning we create them in the laboratories. No? So this includes your trimethoprim, ciprofloxacin, isoniazid. Okay? And then, of course, we have the cross between natural and synthetic drugs. So these are the semi-synthetic drugs. Okay? So these are modified natural drugs. Okay, so these are still natural drugs, but they were enhanced. No, their actions are enhanced by the addition of some chemical compounds. Okay, so like your ampicillin, carbapenicillin, and methicillin. Okay, so antimicrobials may be able to kill microbes. We call them bactericidal, or they could just simply inhibit the microbes from growing or dividing. They don't really kill the microbes. Okay, so bacteriostatic, like your chloramphenicol, your tetracycline, your erythromycin. Okay? Bactericidal, on the other hand, would include your gentamicin, no? Amikacin, and your streptomycin. So these are your aminoglycosides. Okay. So these are the specific actions of antimicrobial drugs. Okay, so they may be either bacteriostatic or bactericidal. Their action specifically would be any of this. No, it could be inhibition of cell wall synthesis, inhibition of cell membrane function, inhibition of protein synthesis, inhibition of nucleic acid synthesis, or okay, they could inhibit other metabolic processes like inhibiting formation of certain uh, vitamins, certain acids necessary for metabolic processes like folic acid synthesis. So some antimicrobials may inhibit the pathway to forming folic acid, for example. Okay. So let's start with cell wall inhibitors. So cell wall inhibitors are those that are uh, known to be selective. Okay? They have a very high therapeutic index, meaning known they're very effective. They have been proven to be effective. Okay, so their actual activity against the agents is to inhibit transpeptidase enzymes. Okay, recall this particular enzymes is very important to ensure that that the bacterial cell wall is intact. Okay, so what's in the bacterial cell wall that would need transpeptidase enzymes. Recall, the cell wall, bacterial cell wall has unsay naa, di ba na ay peptidoglycan. And peptidoglycan is divided into NAM and NAG. Remember? So your N-acetylmuramic acid and your N-acetylglucosamine. Di ba? So yun yung dalawang components ng bacterial peptidoglycan. Okay? Those NAM and NAG are held together, no, by peptide bonds. Okay, and peptide bonds are formed in the presence of transpeptidases. Okay? So, kung ma-inhibit ang transpeptidases, walay peptide bonds. O kung walay peptide bonds, bungkig ang imuhang nam and nag. Kung bungkag ang nam and nag, bungkag pud ang peptidoglycan. Mauna siyang mamatay ang bacterial agent kung ma-inhibit ang transpeptidase enzyme. Nagets? At sino ang lalong kawawa, no? Pag nasira ang peptidoglycan. Eh, di ba ang gram-positive? Kasi ang gram-positive ang may makapal na peptidoglycan. Yun yung pinaka, no, importante na laman ng kanilang cell wall. So, kung mabungkag ang peptidoglycan sa gram-positive, bungkag po dyan siya. Okay? So, examples, we have your bacitracin, your beta-lactams, your isoniazid, and vancomycin. Okay? So, na-discuss na ito previously, ha? So bacitracin would inhibit synthesis of peptidoglycan precursors. Beta-lactams would inhibit transpeptidation, the process mismo. Isoniazid can be bactericidal or bacteriostatic. And vancomycin inhibits translocation and elongation of peptidoglycan. So murag mo up lang ang peptidoglycan in a specific area in the cell wall. Okay? So next are the protein synthesis inhibitors. Okay. Protein synthesis inhibitors, these are those that are able to bind to the ribosomal subunit, the smaller ribosomal subunit. So this would result in the misreading of mRNA. Hindi makatrabaho ng mabuti yung small unit. Diba parang ganun yun, no? Yung small subunit, ganyan. So didikit yung protein synthesis inhibitor. So mali-mali yung pagbasa niya ng mga codons natin, which should code for amino acids. And amino acids, pag na-compile sila together, make up the protein. So kung mali-mali ang pagbasa ng ng ating codons or aminoglycoside, edi syempre mali din yung protein na ma-produce. Okay? So it would target basically most of the organisms, no? Aerobic, anaerobic, gram-positive, gram-negative. Okay? So these are quite effective, no? Protein synthesis inhibitors are quite effective in M. tuberculosis or Bacteroides fragilis, Neisseria meningitidis, Haemophilus influenzae, and Streptococcus pneumoniae. So next is the nucleic acid synthesis inhibitors. Okay? So these are those that are able to inhibit the enzymes that are necessary in creating the chromatin or the genetic material. Okay? So like rifampicin, it inhibits RNA polymerase, and syempre synthesis of nucleic acids, quinolones, which are effective for enteric bacteria like E. coli, and metronidazole, which would disrupt the genetic material or DNA, and they are quite effective against anaerobic bacteria. Then we have cell membrane inhibitors. So they would inhibit the activity of the cell membrane. Remember, the most important function of the cell membrane is the selective permeability. Okay, so it is able to allow entry and exit of materials. Okay, so if a cell membrane components are inhibited, so magiging problema yun, no? Magiging problema ang exit and entry of materials, at saka hindi magiging successful, no, ang metabolic processes ng organism. So examples are polymyxin B and polymyxin E, no, which are quite effective against gram-negative bacteria like your Pseudomonas. Okay, and of course we have the essential metabolite inhibitors. Okay, these are those that are able to inhibit pathways of the formation ng ating mga materials like folic acid inhibition, no? So sulfamethoxazole, for example, inhibits a specific pathway of folic acid. Okay? And then si isoniazid is a cord factor inhibitor. Remember, cord factor is an important virulence factor of your Mycobacterium tuberculosis. Okay? Actually, it is responsible, no, for the ability of the organism to produce other virulence factors, no? So yung cord factor niya. Okay, what else? Your trimethoprim sulfamethoxazole. These are synthetic drugs. Okay? They are usually in a compound, okay? Or combined in trimethoprim sulfamethoxazole. Okay? So let's move into the assay itself, no, antimicrobial susceptibility testing. So the principle of this is to measure, no, or to check if the antibiotic is indeed able to inhibit bacterial growth or to kill bacterial organisms. Okay, so our goal here is to determine whether the bacterial isolate is sensitive or resistant, no? So you'd like to check, okay, whether they are affected, no, by the antibiotics or if they're able to resist antibiotics. Okay? So the purpose, okay, is to guide, okay, the clinician to guide the clinician in selecting the appropriate treatment regimen, no, for the patient. And at the same time, the results will be added into the epidemiological data on microbial resistance, no? Because it's a really big problem in the healthcare uh, world, yung ating microbial resistance. Okay? So that's why most, no, if not all, pharmacies would require prescriptions for some drugs, okay? Because we do not want to, especially antibiotics, no? Because we do not want to increase, no, or add on to the number of microbial resistant organisms, okay? So in this particular assay, we need to be able to grow the organisms and then kill them afterwards. No? So patubuon sa nato, pag human, butangan nato sila antibiotics and see if they are affected by the antibiotics. So in this assay, it's important that we are able to standardize everything that we use so that we could reproduce it, no? And retain the consistency in the process. Okay? So standardization is important because we need to optimize bacterial growth conditions. We need to optimize conditions for maintaining antimicrobial integrity and activity. And at the same time, ayun na nga, no? We should be able to reproduce, okay, the process. Pwedeng ulit-ulitin if you're not satisfied with the results or if there are questionable results afterwards. Okay? So there are actually several methods for AST. Okay, we have the diffusion method, which is widely used. We have the dilution methods, and we have recent methods like the e-test. Okay, so in diffusion, we will be able to get, no, the MIC. Okay, madali siyang also in dilution, no, we can get both MIC and MBC. For e-test, we can actually get the MIC, okay, for this particular step. Okay, so let's start with this diffusion or diffusion method. Okay, it simply means that we will allow, no, antibiotics in a disc, okay, to diffuse into the culture media and observe the reaction of the organisms towards it. Okay, one common method under the disc diffusion is the Kirby-Bauer technique. Okay, so Kirby-Bauer is an agar diffusion method. It usually would require the use of the Mueller-Hinton agar. And of course, we need to standardize our inoculum. Kasi nga, di ba? Okay, we need to be able to repeat it or reproduce the process. And so we need the standard, no, for our inoculum to ensure na tama yung amount ng organism. Okay, so we usually use the 0.5 McFarland standard, which is also known as the barium sulfate suspension. Okay, it is believed to be similar to a bacterial inoculum, no, or bacterial solution that would contain 1.5 times 10 to the 8 na microorganism or ilan yun. So, mga 1, 2, 3, 4, 5, 6, mga 150. Okay? So, ang dami, no? or 1.5 million, okay, na organisms or 150. Hanap na tayo ng ballpen. Mag-compute nga tayo ng tama. Oo. Ang hirap na hindi tayo masyado sa math. Ayun na nga. 'Di ba? 150 million nga, tama, no? So, 150 million. So, the standard 0.5 McFarland is similar, no, to an actual bacterial solution containing 1.5 times 10 to the 8th or 150 million bacteria. Okay, per ml. Yun, no? So, pag nakuha natin, gaya nung nasa picture, ayan, no, halos pareho lang, di ba? So, against a printed material, this is water. You can actually see through how black, no, the prints are. And then this is the 0.5 McFarland standard. Somewhat cloudy lang siya. Somewhat lang. Okay? And so this type of cloudiness or turbidity, that's the word. Okay? This specific turbidity is equivalent to, no, the turbidity of a solution na merong 150 million na bacteria. So yun yung gusto natin ma-achieve when we do AST. Okay? So the pH is also very important. So you have the medium, you have the standard, you have the inoculum size, and of course the pH. So pH is ideally around 7.2 to 7.4. Okay? So the usual culture media is Miller-Hinton agar. Okay, so this is really good for most organisms. These are the components, no? May beef infusion, nucleic acid, vitamins, casein, and agar, etc. Okay, so you can use it plain as it is. I believe you have used that in your laboratory previously. However, we can improvise this to fit the needs of your organism. Like for example, kailangan mo ng mag-grow or ang i-grow mo, yung na-identify na organism is oxacillin-resistant staph, no? Oh, so pwede nating lagyan yan ng 2% sodium chloride, no, to facilitate the growth of staphylococci, which is a halophil, no? And then you can also use or add 5% lice, horse blood, or sheep's blood, okay? Para naman ito sa mga streptococci, Neisseria meningitidis, and other fastidious organisms which would grow, no, more efficiently in the presence of blood. Okay? So, pwedeng mag-add ng sodium chloride, pwede din mag-add ng blood sa inyong Mueller-Hinton. But, of course, you can use it just as it is. Okay? So, your Kirby-Bauer test would require, no, your Mueller-Hinton. Its depth should be around 4 mm, no? So, ang kabag-on for bacterial culture, 4 mm, no? Yun yung kakapal ng culture media. Okay? Para tamang-tama lang yung pag-diffuse ng ating antibiotic from the paper disc. Condition, you can simply incubate it after you have inoculated and added the discs. Diretso na yan dun sa ating incubator. Huwag mo lang ilagay yan sa iyong gas pack. No? You don't need to provide additional carbon dioxide except for specific organisms. Okay? So temperature is at 35 to 37 degrees, the usual. Incubation time, 16 to 18 hours or overnight. Okay? Huwag masyadong tagalan dahil magiging false susceptible yung results. Okay? Now, the size of the antibiotic disc is 6 mm. Okay? So kung walang zone of inhibition yan, ang nire-record natin is the size of the disc, which is 6 mm. Okay? And then we also can use the Petroff-Hauser. No? It's quite similar to our Neubauer. No? I know, nakita nyo na si Neubauer counting chamber. So halos ganun din ang kanilang itsura. Okay? Ganun din ang kanilang itsura. So meron din siyang counting chamber. Ang difference lang nila actually is that si Petroff-Hauser at saka yung dimensions ng actually ng chamber nila ang difference. Yung kay Petroff-Hauser, ang chamber niya is 0.02 mm, while yung kay Neubauer counting chamber or hemocytometer, ang kanyang depth is around 0.1 mm. So mas dako, no? Ang depth ni hemocytometer compared sa Petroff-Hauser. Okay? Now, what are the other factors? So, nandun na tayo sa culture media, right? So, kailangan na kailangan yun. Tamang-tama yung culture media na gagamitin mo. Okay? You should also take into consideration, number one, the amount of inoculum. Maunang mag-standard ka, no? We use the 0.5 McFarland standard para approximately 1.5 times 10 to the 8 organisms per ml ang atuang ang present na organism in your solution. So we use our standard as a comparator. Dapat pareho yung ka-turbid ng ating inoculum doon sa standard natin na nakita ninyo kanina, di ba? Secondly, aside sa Miller Hinton, yung agar, yung kakapal, di ba dapat 4 mm? So not too thin, not too thick. Okay? If too thin, you'll get larger zones. And that would mean false sensitivity or false susceptibility. Pag masyado namang makapal, okay, that would make your zones very small. Nga naman na, no? Nga na siya. Okay, so pag manipis kasi masyado, di ba? Eh di walang ibang pupuntahan pag mag-diffuse na, no? If the incorporated antibiotic in the disc will just spread horizontally if there's very if there's a very thin layer of agar underneath it. So ang spread no, ang diffusion niya is sideways or horizontal. Okay? So there would be the zone, no, where the antibiotic has diffused would simply get wider because its spread is horizontal rather than vertical. Okay? However, on the other hand, if your agar is too thick, there'd be too much agar for the antibiotics to diffuse into. And so, palalim, no? Ang kanyang diffusion is vertical rather than horizontal. Okay? So that would result to really small zones because the antibiotic would just go right down at the bottom of your agar. Okay? Naintindihan ba yon? Okay? So, pag manipis, walang ibang pupuntahan yung antibiotic na nasa disc. Pag nag-diffuse yun, kasi wala na siyang pupuntahan sa baba dahil napakanipis, di pag nag-spread yun, pag ganun. Okay? Samantalang kung napakakapal naman ng agar, yung antibiotic mo sa taas, mag-diffuse siya pababa. Okay? Pababa ang diffusion niya. Wala masyadong diffusion sideways. Meron man, very minimal. And so, maliit lang yung zone of inhibition. Nagets. Okay? So, kung maliit, manipis, large zone, false susceptibility. Pag makapal, maliliit ang zones, so false resistance naman. Okay? So, agar, inoculum size. Sa agar mo, dapat yung thickness. Okay? And then yung inoculum mo. Okay? Next is the growth rate, yung organism natin. Okay? So, kailangan mabuhay sila. No, 'di ba? So pag inoculate natin, dapat tama ang inoculation temperature, which should be 35 degrees Celsius. At tama rin ang duration, which is 16 to 18 hours. Okay? So kung masyadong mainit, baka mamatay. Masyadong malamig, hindi na mabuhay properly. Kung masyadong matagal, okay, false susceptibility niya, no? Kasi natagalan sila masyadong na-expose sa drug. Okay? Pero kung less than 16 naman, baka baka maliit pa ang zone of inhibition. Okay? However, there are some cases where we could release results na 6 hours lang. Okay? Meron din naman kasi iba na sensitive sila masyado sa antibiotic. So, immediately, yung results, nakikita siya. So, ang pinaka-initial na reporting natin may be done after 6 hours of incubation. No? However, we still would release the final result after makomplete yung 16 to 18 hours. Okay? So, except for emergency cases, pwedeng 6 hours incubation. Okay? Next, what else? So, temperature, dapat 35. Okay? So, pag higher than 35, this may lead to false detection of MRSA, no? Or pag lower naman, magiging larger ang zone of inhibition. Hindi sila masyado tumutubo. Okay? So, if kailangan sila no? Kailangan yung carbon dioxide kasi capnophiles, dun lang tayo maglalagay ng 5 to 10% increase in carbon dioxide. Pag hindi naman siya capnophile, wag mong lalagyan. Why? The excess carbon dioxide will decrease, no, the pH. So magiging acidic, no, ang pH ng iyong culture media. Okay? So, ang pH, ano yung ating target dito? 7.2 to 7.4 kasi slightly alkaline yung ating or neutral, no? Neutral to slightly alkaline ang best para sa ating organisms. Okay? So, dapat kung hindi naman kailangan, wag lagyan ng carbon dioxide because this will decrease pH. Okay? At if there is exposure to tetracycline drugs, okay, this may lead to no, if there's increase in pH rather, no? So kung naging alkaline, okay, bumababa, nasisira yung tetracycline drugs. Okay? So hindi siya maganda para sa mga antibiotic list natin containing tetracycline drugs. Okay? And then pag acidic din naman, okay, ang acidic na pH would affect other antibiotics like aminoglycosides and erythromycin. Okay? So dapat 7.2 to 7.4. Okay? Wag maglagay ng maraming carbon dioxide as it tends to make your agar acidic. At pag acidic, hindi maganda for your aminoglycosides and erythromycin. Okay? Pag alkaline masyado, hindi rin maganda para sa tetracyclines mo. Okay? Next, ilan ba dapat na disk ang pwedeng ilagay natin sa ating sa plates, no? So, pag yung regular lang na 150 mm, o 55 rather, no, yung maliit lang, ano lang siya, yung 50 mm natin or 55 mm nasa 5 to 6 discs. And then yung ating 150 mm, yung malapad, okay, pwede siyang 10 to 12 naman. Provided na meron tayong mga distansya. Okay? So, kailangan may distansya para maiwasan yung overlapping of zones. Okay? So, again, no, yung ating kailangan bantayan doon is yung type ng agar mo, okay? Mueller-Hinton, the thickness, the pH, okay? Yung growth ng iyong organism, tama, dapat lang ilagay sa 35 degrees Celsius and incubated at 16 to 18 hours. And then yung iyong inoculum size, dapat pareho dun sa 0.5 McFarland standard or it should contain 1.5 times 10 to the 8th na organism per ml. And ano pa, dapat hindi masyado marami ang discs, no? Para hindi mag-overlap yung mga zones. Okay? Meron pa ba tayong nakalimutan? Wala na. Okay? Sure na ba tayo? Tingnan nga natin ulit. Wala na nga. Na-cover na natin. Okay. So, this is an illustration of or a flow chart of how you're supposed to do Kirby-Bauer technique. So, of course, first thing is dapat meron tayo ng ating 16 to 18 hours, no, or overnight na culture na may colonies. Okay, kukuha tayo ng sample dyan, a loopful. It's transferred into a tube of trypticase soy broth. Okay? In some cases, they use NSS. Okay? Pwede naman yun kasi hindi naman natin isi-store. So, ipaprocess naman din natin agad. After inoculation of your broth, pwede natin itong i-incubate for about 3 hours. Okay? Para to allow the organisms to grow. After that, no, we prepare our standard and yung ating sterile distilled water. So, dito natin ililipat, no, yung TSB drop by drop until we reach the same turbidity as our standard. Okay? So, after natin nag-incubate ng 3 hours, so we get several drops of the TSB na magiging turbid na yan. So, hinay-hinay kang mag-a-add dito sa iyong sterile distilled water tube until pareho na sila ka-turbid. Okay? So, once you have achieved the same turbidity as your standard, you can now inoculate. So, asa ka makuha? Siyempre, di rin nakamukuha. Kanina imuhang inoculum. So, dip your swab here and then inoculate using your lawn technique. here sa ating Mueller-Hinton agar. Okay? So, after inoculating using the lawn technique, no, let it stand for several minutes. Okay? And then you can add your discs. Okay? So, ito yung sa regular size lang. Pero pag ganito yung gamit natin, yung malaki, pwede yung 10 to 12 discs. Make sure may mga spaces. Okay? So, after a minute, after allowing the discs to settle, you can now incubate your plates. Okay? So, leave it in the incubator, no, overnight, and then you can check back on it pagkabukas. Okay? So, ang antimicrobial susceptibility testing natin is very specific dapat. Okay? So, if you're going to use yung 150 mm, okay, so dapat lang yan 12 discs. Yung maliit lang, no, pwede tayong 5 to 6 discs. Remember, approximately around 15 mm ang disc distance natin. Okay? So this is a list of reasons why we have false resistant and false sensitive reactions. Okay? So we have for false resistance, okay, if disk application has been delayed, no, so 15 minutes, ang tagal, okay, magiging resistant na sila. Bakit? Okay? After inoculation, pinastand mo for 15 minutes. Ay di na tumubo na yung organism mo, mas marami na kaysa sa kaya nung concentration ng antibiotic na nasa disk. So, baliwala na lang ang disk. Gamay lang kaayo ang mga matay. Kaya protein na lang daghana. Okay? So, on the other hand naman, 15 minutes delay of incubation. Hindi ka naka-incubate agad-agad. Okay? Pwede rin itong mag-lead to false sensitivity reactions. Ayun, no? So, dalawa, no? So, kung natagalan kang maglagay ng disk, okay, pwedeng maging false resistant kasi dumami ang microbes. At the same time, okay, pag hindi ka naman naka-incubate agad, okay, o dahil na-delay ka dun sa iyong disk application, tapos yung organism mo ay sensitive sa temperature, okay, mamatay kung dili maka 35 degrees Celsius, mamatay sila. So, mag-false sensitive ka din, no? So, either way, okay, pag sumobra ka ng 15 minutes, whether sa paglagay ng disk or sa pag-incubate, hindi maganda ang resulta. Next, pag masyadong naging marami ang moisture, okay, so madilute pod ang imuhang antibiotic. Okay? So magiging fault resistant. Okay? And then pag na-dry naman, no, yung ating dehydrating yung culture media, hindi din maganda ang growth ng organism. Mamatay sila, no? Kaya desiccated sila. So, false sensitive din ang ma-achieve mo. Okay? And then, pag masyadong makapal ang culture media, okay, thick ang medium, you'd get false resistant as explained earlier. Diba? Kasi ang diffusion niya, pag makapal ang medium, malalim. So, ang diffusion nun, vertical, dire-diretso sa baba. Hindi masyado siya nakakapag-diffuse horizontally. Okay? Unlike kung thin ang medium. So, if the medium is thinner than 4 mm, okay, so ang tendency is it wouldn't be able to diffuse so much downward. Rather, it would diffuse sideways where there's still space for diffusion. Okay? So, what else? Pag masyadong marami ang iyong organisms, oh, yung nasobrahan ka nga, no, hindi ka nakapaglagay agad ng disk or hindi mo na nasobrahan mo yung pag add ng yung microorganisms from TSB to sterile distilled water, so that would increase your organisms. Hindi ka na dun sa 1.5 times 10 to the 8. Baka 1.5 times 10 to the 10th na. Eh, dami na, masyado. So that would lead to a very small zone of inhibition. Whereas kung gamay lang po din mo ang organism, hadlo ka mag-add, kaya basig masubraan ka than your standard. So ang tendency is, ako kay kag zone of inhibition. Kay wala day kay nabutang kay nga organism. Okay? So, how do we read our plates? Okay? So, remember, nung nag-inoculate tayo, lawn technique ang ginamit natin, di ba? Ang purpose ng lawn technique is that makarpet makoveran mo yung buong surface area ng iyong Mueller-Hinton para ang growth ng organisms natin is confluent or at least almost confluent like in the picture that you see here. So ibig sabihin nun, halos so dikit-dikit na sila masyado para 'di ba maganda yung itsura ng ating zone. Okay? So the area, the lawn should be confluent. Mahirap pag non-confluent. Ang labas nun, ang raming butas-butas, ang raming area na walang tumubong colony. Okay? And then measurement should be done using a vernier caliper like you see here in the picture. Pero pwede rin naman ang ruler basta may millimeter lang na measurement. Okay? So dapat clear ang zone of inhibition. No, dapat walay colony sa sulod. Pero kung naaman, just record the results and indicate na meron kang mga individual colonies na tumubo dun sa zone of inhibition. Ayan. So ano ba yung mga results na pwede nating makuha with your AST? So AST may result in either susceptible result, intermediate, or resistant. How will we know? Pag resistant, walang zone of inhibition. So tignan natin itong tatlo dito. Ayan, no? So itong isa, wala siyang, sa letter A, wala siyang zone of inhibition. Okay, ibig sabihin nun, walang effect ang antibiotic sa organism dahil up to the edge, may tubo siya. So that's resistant. Okay? Now, what about susceptible? Okay, so ang susceptible, may malaking zone of inhibition. So ibig sabihin nun, the microorganisms respond no, to the antimicrobial agent by not growing around it. Okay? So, pag masyadong malaki, anyway, meron naman talaga tayo nitong specific ranges, no? Size ranges ng zones of inhibition na masasabi nating susceptible. Okay? So, dako siya kaayo. Okay? And then we have resistant, ay intermediate. Okay? So, pag intermediate, meron siyang effect, no? Yung drug ay may effect sa organism, pero dili lang yun ing ana ka dako, no? Compared sa susceptible reaction. Like this one, si B. Si C, susceptible kay dako kaayo, no? Pero dapat i-measure gid na siya ang iyang zone of inhibition, yung diameter. So kung meron naman, we don't need to memorize that, okay? Kasi meron talaga yan sa laboratory. So kung umabot siya dun sa, for example, ang nakalagay dun sa literature, no? Like erythromycin for say gram-negative organism. Okay? So ang ang nakasulat doon, pag susceptible dapat ang diameter is nasa 16 to 22. Okay? mm. Tapos pag measure mo, ang zone of inhibition niya is 19 mm. So pasok siya sa susceptible. Pero like for example, ang nakalagay dun sa ano is from 20 to 30 mm ang susceptible. Okay? Tapos hindi siya nakaabot, nandun na siya sa 18 mm. Dako naman na kayo, no? Pero hindi siya umabot sa susceptible. Okay? So saan natin siya ilalagay? Pwede siya, baka mahulog siya dun sa intermediate. So, pag intermediate, yung reaction ng organism sa antibiotic falls into a range of susceptibility pero less than the susceptible strain. Effective din siya, pero kailangan nito nung mahabaang treatment. Okay? So, naintindihan. Pag susceptible, malaki yung zone of inhibition, kagaya nitong kay C. Okay? And most especially if nakapasok siya doon sa range na nakasulat doon talaga sa listahan. Okay? So, pag intermediate naman, may zone of inhibition, ani, pero dili kay siya dako. Okay? Pag resistant, wala dyan zone of inhibition. Now, unsay significance aning intermediate na result? Okay? So, sometimes, may effective talaga. Like si drug C, for example, effective jud siya. Okay? Pero, dili siya the patient would experience mga adverse side effects. Okay? So, if that happens, okay, ang tendency is the doctor would find drugs that are less effective. Okay? Effective still, pero less ang kanyang strength, no? Na wala siyang adverse side effects sa patient. Okay? Pero usually ang treatment nito nasa 2 weeks, no? Ganun mahaba. Kasi hindi siya ah, as or bilis nung drug kung saan susceptible masyado ang organism. Naintindihan, no? Sana naintindihan naman yung difference ng ating susceptible at intermediate. Okay. So going forwards, so dito naman tayo sa dilution method. So here, okay, we can do agar dilution or broth dilution. So what does that mean? Okay? Pag broth dilution, ganito yun, no? Usually ito yung ginagamit dati to acquire MIC. Okay? So pag may zone of inhibition ka na, may sensitive result. Okay? So ang sensitive result nun, say, ang ginamit natin na concentration is 30 micrograms or 30 micrograms ng drug, no? Ang nagpakita ng susceptible na reaction. So from there, pwede tayong mag-check kasi baka pwede pa siyang i-lower down, okay? Na effective na rin siya. So you can start from 30 microgram and then 25 micrograms, 20 micrograms, 15 micrograms, 10 micrograms. Okay? So ito, iba-iba ang kanyang concentration. Okay? So meron kang control, positive control at negative control. Okay? So i-dilute mo ngayon yung iyong organism. Okay? Sa kanyang iba't ibang concentration ng drug. Yun na nga, no? So aside sa 30, may 25 microgram, may 50, may 20 micrograms, or in this case, okay, meron siyang 8 micrograms, no? Say yun yung pinakamataas, doon siya nag-positive for susceptible, no? Susceptibility sa 8 micrograms in your zone of inhibition. Okay? So sa Kirby-Bauer, kanya Kirby-Bauer ka, ang ginamit mo na drug doon is 8 microgram, no? O say 8 micrograms ng penicillin, for example, doon siya nag-positive. Okay? Sa 8 micrograms na penicillin. Tapos sa ibang drugs, hindi siya nag-positive. So pwede kang mag-test, no? You'd like to see how low, you can use para mamatay yung microorganism. So 8 micrograms, doon ka nag-positive. So but you can go, no, lower by twofold dilution. So 8, 4 micrograms, 2 microgram, 1 microgram, 0.5, 0.25 micrograms. Okay? So, eto may mga nakadilute na dyan yung iba't ibang concentration. Yung sinasabi natin 8, 4, 2, 1, yun yung microgram or concentration ng drug. Okay? Say ng penicillin. So, iba-iba. Ngayon, titignan natin dyan kung saan ba yung concentration na wala ka nang makitang visible growth or hindi na siya turbid. Yun, no, would be the MIC or minimum inhibitory concentration. Again, that's the lowest antimicrobial concentration that would completely inhibit visible bacterial growth. By visible meaning turbidity. No? So, asa dito itong pinakamubo na concentration na dili na turbid. Motoy MIC. So, looking at this lineup of concentrations, you have 8, clear na, hindi turbid. 4, hindi na rin turbid. 2, hindi rin siya turbid. 1, medyo purplish, no? Medyo turbid. 0.5 turbid, Jud. 0.25, labawang turbid. Doon na kayo siya sa 0. Okay? Ito yung walang drug, no? Pero merong bacteria. So, turbid kaayo. Okay? So, dito, meron tayong tatlong tubes na clear na. But the lowest concentration among the 3 tubes is the 2 microgram. So, mauna ang MIC. Now, to check, kasi sa MIC, ibig sabihin na nun, visible lang. Visibly, you can't see growth. Okay? Pero you cannot say na wala talagang growth dyan. So, to know whether or not may organisms pa, we find the MBC, which is the minimum bactericidal concentration. So how do we do that? We prepare culture media. Kahit yung Mueller-Hinton lang, pwede na. Or nutrient agar, pwede na rin. Okay? Walang drug doon. Okay? Just plain nutrient agar. i-culture natin. Sino culture natin? Pwede mong i-culture yung tatlong clear na. Or etong ginawa niya dito, ang kinulture niya, si 4, si 2, at si 1 microgram. Okay? Pero obvious naman kasi medyo turbid pa, may tubo talaga yan. Eh, pwedeng ito na silang tatlo. No? So, depende sa protocol ninyo. Okay? Pero, para dito sa illustration, yun nga ang ginamit niya, no? Yung 4, 2, and 1. So, ang 1 microgram, which appeared to be slightly turbid, nandun siya colonies. Okay? Si 2 microgram, which is the MIC, no? Wala na din siya turbid, apan naagyapon siya colony. Pero si 4 microgram, wala na itubo. Okay? So, this is our MBC. Okay? So, si 4 microgram is the minimum bactericidal concentration or the concentration, the lowest concentration that's observed to be able to kill bacteria. Okay? So, sa MIC, ano lang, no? Inhibition of growth. Visibly inhibits growth is 2 micrograms. Pero yung concentration na talagang patay na yung organism is 4 micrograms. So, pili lang ka. Ito, pwede yung maging intermediate. Ito, talagang susceptible. So, pwede mo siyang ibigay sa pasyente pag medyo sensitive na yung pasyente. Pero kung hindi naman, dito tayo syempre sa mas mataas na concentration. So, that's broth dilution. No? Gasto siya kay lain-laing concentration per test tube. Okay? Compare dun sa iyong Kirby Bauer kanina. Di ba sa Kirby Bauer, pwede kang maglagay ng 12 different types of antibiotics na may iba-ibang concentration. Ganun. Di ba? Kaya yung ginagamit natin. Eto, kung meron kang 10 antibiotic na itetest, di 10 setup din. Okay? 10 setup yan. Okay? Then we have agar dilution. Okay? So sa agar dilution naman, similar lang siya nung broth dilution, kaya lang sa plates lang siya. So gasto gyapon kay nga no, tag isa ka plate kada concentration. Di ba nakita nyo kanina, 8 microgram, 4 micrograms, 2 microgram, 1 microgram. Lahi-lahi og container kada concentration. So kung nakay again, so dahil 5 to no, 8, 4, 2, 1.5 micrograms. Isa lang na antibiotic, penicillin. Kung napagid kilain pa, another 5 tubes. So gasto kaayo. Okay? So ito ganun din, no? So kung meron kang 8, 4, 2, 1.5 and then your 0.25 micrograms. So kuan kay siya, no? Kalas-kalas kaayo. And then ito yung ating e-test or the epsilometer test. O di ba? This one is also known as the gradient diffusion test. Yung drug is already concentrated, is already incorporated in the disc, and they are incorporated in gradients. Okay? So, mas matapang dito hanggang pakonti ng pakonti yung laman niyang antibiotic. So, hindi zone of inhibition ang tinitingnan natin dito kasi hindi nga siya bilog, di ba? Pahaba. So, elliptical na zone ang hinahanap natin dito. Ayan. Okay? So, ang pag-inoculate, pareho lang good, no? Ang inoculation long technique. And then, ayan, i-apply mo na yung strip mo. May template siya na ginamit para alam niya kung saan niya ihuhulog yung strip na may distansya. Template yung nasa baba. Okay? And then incubate, no? The next day, ayan na. Oh, di ba ang cute? Oh, so tignan nyo, nasa dulo niya, yun na yung MBC. So this is quite simple to do. Medyo may kamahalan nga lang. Pero ayan na, may MIC ka na. Hindi mo na kailangan mag-prepare ng broth dilution mo. Di ba? So kung saan nakatuon yung dulo ng ellipse niya, yun yung MIC. So in this case, ayan. So kung i-close up natin, makikita mo may colony pa dyan. So ang pinaka-area na clear na yung kanyang edge would be sa 4 micrograms. Ayan. So yan ang kanyang MIC. Okay? And of course, we can also do your automated systems dito sa ating for our AST. So meron na tayo ng Vitec 2, no? Aside from bacterial identification, you can also perform AST here in the Vitec 2. You can also have microscan walkaway systems. No? You have the Beckman Coulter. You have the Phoenix also by BD. Ayan, so marami na tayong nagagamit na machines sa laboratory, no? For your for susceptibility testing. Okay? So, moving on. Gusto ko sanang putulin pero wag na lang. Dire-diretsuhin na lang natin 'to. O part 2 pa rin. Dapat ito ay part 3 na po. So part 3 no ng ating topic for this week is microbial mechanisms of pathogenicity as well as principles of disease and epidemiology. Mostly itong topic na to is terminologies lang naman, no? And I know you're familiar with them also. So the purpose lang nito is for you to refresh your memories about the different terms involved in epidemiology, disease process, and pathogenicity. Okay. So, when we're talking about microbial mechanisms of pathogenicity, we are talking about ways by which these small organisms can cause damage sa mga kalalaking katawan gaya natin, di ba? Eh sila ang liliit nila. How are they able to cause infections? How are they able to cause damage in our body? Okay? So, iisa-isahin natin yan. Again, no? Let's review. Ang pathogenicity is the degree of what? Pathogenicity is the ability to cause disease, no? Degree of, ang virulence naman is degree of pathogenicity. Okay? So, kung virulent ka, ibig sabihin nun, ang taas ng degree of pathogenicity ng organism. Ang pathogenicity is the ability to cause disease. Pag sinabi mong pathogen, yun yung organism. Pag sinabing pathogenic, disease-causing. Pathogenicity, ability to cause disease. Virulence, degree of pathogenicity. Okay? So the higher the degree of pathogenicity ng isang organism, the more virulent it is. Okay? Hindi ibig sabihin pathogenic din ay virulent agad. Okay? Meron namang nakakapag-cause ng infections na hindi naman severe. Pero yung nakakapag-cause ng severe na infections, yun yung mga virulent. Ganun. Okay? So, ano ba yung kailangan nating malaman? Okay? Your organisms are pathogenic because they're able to enter and exit host systems. Okay? So, kung naalala pa natin yung chain of infection, no? So, nandun yun, di ba? Pwedeng mag-spread ang infection because number 1, they're able to enter host cells, and number 2, they're able to exit host cells. In between, no, they're able to cause damage because they are able to grow and attach themselves, colonize inside the host's body. Okay? So portals of entry unsa man dinhi sila? Mao ni to mga pwede nila sudlan sa atong body. So organisms can enter through mucous membranes, no? Mata, ilong, bunganga, your genitals, ganun. Or sa skin, no? If you have breaks on skin, ayan, may mga sugat-sugat ka, or parenteral route sa mga injection na ganyan, no? Mga dextrose na ganyan. Okay? Portals of exit on the other hand, syempre ito yung paano sila lumabas sa reservoir, right? So, organisms are able to exit the body by, via the respiratory tract through coughing, sneezing, talking, okay? Sa gastrointestinal tract naman, pwedeng via saliva or feces. Sa genitourinary tract, via urine, vaginal secretions, urethral secretions. Sa skin, again, yung mga lesions doon, no? Kanang nuka-nuka, ayan. And then, blood, no? Sa arthropods, di ba? Yung pag sinipsip yung dugo mo. Okay? Or sa mga contaminated needles or syringes. Okay? So, again, gaya ng sabi ko kanina, pag nakapasok sila sa body natin, no, using our portals of entry, or pag nakalabas sila galing sa infected host, no? Again, using the portals of the mucous membranes, no, skin, and no, yung lumalabas na excreta or body fluids. And of course, importante rin sa pagiging virulent nila, yung ability nila to stay inside the body by adhering sa ating mga host cells. So adherence is a very important mechanism of pathogenicity. Okay? So adhesins or ligands bind the organisms to host cells. Okay? So halimbawa ng mga adhesins are the glycocalyx, no? Yun yung ginagamit ng Streptococcus mutans natin, Fimbriae ni E. coli, may period pa si Escherichia. Okay? M protein, okay? Which is commonly found sa surface ng Streptococcus pyogenes. Di ba para siyang parang katong Fimbriae. Okay? Kasama siya doon sa Fimbriae nila. Okay? And then OPA protein, which is responsible for opacity ng colonies ng organism. Okay? Yung pagiging intact ng colonies ng organism. So this is common in Neisseria gonorrhoeae, and yung tapered ends. Okay? Tapered ends ng spirochete like kay Treponema pallidum, tsaka kay tawag nito kay basta sa spirochetes, no? They have tapered ends which would allow them to hook themselves sa mga membranes. Okay? Leptospira pala. Okay, leptospira. Okay? And then of course, aside from their adhesins, structures like the capsules or the glycocalyx, So, ito ay these are also able to contribute to microbial pathogenicity. Kasi nga, di ba, pag encapsulated, hindi ito basta-bastang digest ng ating mga phagocytes. And of course, if they have organs of locomotion like flagella or eggshell filaments for your spirals, o di po sila dahil madakpan kay makadagan ang atoang organism. So these are factors again that would contribute to their ability to become disease-causing. Okay? And syempre, okay, aside from the fact that they are able to enter, exit our body, adhere to the body, they're also able to damage our cells because of the enzymes that they produce. Okay? So coagulase enzyme. Remember, ang coagulase enzyme will coagulate blood, di ba? Ginagamit nila ito pangtago para dun sa hindi sila makita agad ng mga phagocytes, no? So imagine mo criminal ning ato ang organism, specifically di ba si Staphylococcus, sa kanya naman yung coagulase enzyme. So imagine nyo, si Staphylococcus mura ka ng wanted na criminal, okay? So may dumaan na phagocyte, nakita ni Staph, okay? At dahil alam niyang mahuhuli siya, so maglalabas siya ng coagulase. Okay? Paglabas ng coagulase, yung fibrin sa palibot, magka-clot yan. And so, pag may clot na, natabunan siya, parang nagkukun siya ng fibrin clots. Tinago niya yung sarili niya. Okay? So, labian na siya sa phagocyte. Ang fibrin clot is a normal site in areas that would require repair. Okay? Common site na siya sa body nato. So, agian na sa phagocyte na siya, phagocytose. Okay? So, paglabay sa phagocyte, edi free naman siya, di ba? Pero paano siya makawala dun sa kanyang kukun ng fibrin clots? By using kinases, the organism will be able to free itself from the fibrin clot, right? No? Okay? So, after nilang magtago, kailangan na nilang mag-resurface. So, magpapalabas sila ng panibagong enzyme like the kinases, which would digest their fibrin clot. So, free again ang organism. Unya, unsa pasod? Naapadyud sila ay hyaluronidase. So, ang hyaluronidase is also known as the spreading factor. It attacks or hydrolyzes the hyaluronic acid. Di ba? Kanitong cement, no? In between our cells para maporma ang tissue. So, kung naang hyaluronidase, the organism will feed on the hyaluronic acid. So, mag-loosen ang cells, no? So, pag nag-loosen ang cells, edi madali na lang mag-spread yung infection. Madali na lang kumalat yung infectious agent. What else? Collagenase o enzymes that would hydrolyze collagen. Di ba? Connective tissue din yung collagen, di ba? So, pag nakain yung collagen, edi mas mabilis silang again kumalat. Okay? And of course, some may have IgA proteases. O, di ba? So, bagong-bago lang tayo immunosero, di ba? O, dapat hindi natin nakalimutan yung ating immunosero dahil dito natin nakilala yung ating mga immune globulin. So, isa na doon si IgA. At alam natin si IgA ay mga nakastasyon yan sa ating mga mucous membranes. Ito yung pinakaunang mga sundalo na nakabantay, checkpoint sa atong mga mucous membranes sa mata ni IgA, dire pod IgA, no? So, kung na IgA protease, agoy, okay? Mga gisi, mga bungkag ang IgA. So, kinsa pa may mobantay kung nangawala na ang mga gwardiya sa ato ang checkpoint. So, wala, no? Makapasok agad. Yun yung isang sekreto ng mga madaling pumasok sa mga mucous membranes natin. Na-atake nila yung mga IgA na tigbantay. So, kinsa pa may mobantay ron? Wa na. So, muna, maka-invade ang organisms. Next, ayan na nga si siderophores, di ba? Ito yung katapat ng ating transferrin. So sa tao natay transferrin, no? Tig-absorb ng mga iron, no? Galing sa mga kinakain natin. Pero syempre, growing din naman ang mga bacteria. Kailangan din nila ng iron supply. So napod sila panghigop og iron, and that's their siderophores, di ba? And of course, another capacity, no, of organisms that allow them to become pathogenic is their ability to change antigenic surface antigens nila. Okay? So, if they're able to alter surface proteins, okay, ang hirap nun para sa mga immune cells natin. So, panibagong ano na naman yun, di ba? Konting difference lang sa surface proteins, dili na siya ilahon atong antibodies naghihimo para sa katong unang structure na na-meet niya. So kung nag-mutate or nag-evolve, no, ang katong bacteria, ay ang problema, di na mailhan sa bisag gamay na kay ang change, di na mailhan sa ato ang antibody, no? So maghimo na pud tag panibagong antibody para ato na organism. So antigenic variation or ability to alter surface protein is also a mechanism of pathogenicity. Okay, what else? So aside from the fact that they can produce enzymes, production of toxins are also able, no, to cause organisms to damage host tissues. Okay. So to begin with, toxins, these are substances that contribute to pathogenicity. These are poison. Okay. So these are chemical substances produced by the organisms that are damaging to the host cells. Now, toxigenicity is the ability to produce toxins. Toxemia is the presence of toxin, no, bacterial toxin in host blood. Toxoid, ito yung inactivated toxin na pwedeng gamitin pang bakuna. Antitoxin, these are antibodies against a specific toxin. Okay? So, toxoid at antitoxin, ha? Ang toxoid, toxin siya, inactivated lang. Okay, pwedeng pang bakuna. Si antitoxin, it's an antibody against the toxin. Ayan. So, ano ba yung iba't ibang klase ng toxin? We have exo and endotoxins. Exotoxins are chemicals produced inside the bacterial cells and are released or excreted outwards towards the environment. This one, no, is common in gram-positive organisms. Okay? So, ginagawa sa loob at nilalabas, parang iniihi ng microorganisms. Now, what about endotoxins? Ang endotoxins, endo nasa loob, no? Ibig sabihin nun, part ito ng body ng bacterial cells, no? To be exact, it's part of the bacterial capsule, no? Or cell wall nila rather, no? Part ng cell wall, 'di ba? Ito yung nasa lipo uh, lipo-oligosaccharide, no? Especially kay Neisseria. Nandun 'yan, no, sa cell wall, okay? Yung lipid A moiety nila, 'yan yung endotoxins nila, no? So part 'yan ng bacterial cell. It is only liberated when the bacterial cell dies. Okay? Ito is common in gram-negative. So to summarize, para mas maintindihan natin, anong difference ng dalawa? Okay, yung ating endotoxins, common sa gram-neg. Si exotoxin, common sa gram-positive. Si endotoxins, present siya sa lipopolysaccharide or lipo-oligosaccharide in the case of your Neisseria. Okay? Si exotoxin naman, it's a byproduct of the cell. Ginagawa nga sa loob and then ine-excrete niya. So, endotoxins are, since part siya ng lipid A moiety, more on lipid ang kanyang components, while si exotoxin is protein by nature, Jude. There's no fever sa exotoxins. However, pag affected tayo by endotoxins, it can actually cause an increase in temperature. Okay? Ang exotoxins is neutralized by antitoxins. Okay? However, ang endotoxin is not. No? Okay? So dito naman tayo sa principles of disease and epidemiology. So again, let's define terms, no? When we say pathology, it's a study of disease. Etiology, study of the cause of disease. Pathogenesis, it's the development of disease from incubation period, no, up to or from the time na pumasok yung organism to incubation period up to the time na nagmanifest yung damage, no, caused by the presence of the organism. Infection, this refers to pathogenic colonization of the body, and disease is already an abnormal state in which the body is not normally functioning. Okay? So, pag sinabing symptom, these are usually changes, no, bodily changes that are felt by the patient. Okay? Like nausea, like ano pa ba? Nausea, uh, yung feeling of pagsusuka, okay? Body malay, yan, that's just a symptom. It is usually non-measurable. Signs, on the other hand, are measurable or na-observe natin like fever. Di ba? You can measure it because pwede natin kunan ng temperature. Okay? Heart rate, blood pressure, yan yung mga signs. Okay? Syndrome is a combination of signs and symptoms. Okay? Stages of the disease. Okay? So, disease process, no, ng tao usually coincides with the growth curve of the bacteria. So, if you look closely, at the very beginning here, right, incubation period, ito yung lag phase, no, ng bacteria. Eventually, they're able to synthesize their enzymes, they're able to gather nutrients, we enter the early logarithmic phase. No? Ang early logarithmic phase, ito yung prodromal period. Okay? And then eventually it goes up, it would escalate until such time na full na, no? Yung full-blown na yung logarithmic phase. No? Sunod-sunod na yung signs and symptoms. No? That's the period of illness. Okay? Pag hindi naagapan ng iba, this may lead to death. However, if there is treatment, no? May treatment after nung stationary phase here, pwede itong mag-proceed sa death or decline phase. Okay? So at the same time, si patient naman mag-undergo ng convalescence, no? Di ba? So, kamatch, no, ng bacterial growth curve ang stages of the disease. Nakuha nyo ba? No? So again, incubation period, mauni itong equivalent sa lag phase, no, sa bacterial growth curve. Now, kaning prodromal and period of illness, part ni siya sa logarithmic phase. Ang prodromal nasa early logarithmic phase, sa period of illness nasa late logarithmic phase. Okay? And then, pagdating dito sa top, no, yung ano bang portion to, yung stationary phase, dito actually pwedeng mag-progress to death, no, pag hindi napatreat. Okay? However, pag nagpa-treat, okay, mamatay ang mga organisms, no? Decline phase sila. So at the same time, si patient naman mag-undergo ng convalescent or recovery phase. Okay? So to add, no, sa mga ano natin, mga terminologies, meron tayo nung acute phase, no? So acute diseases are those that develop rapidly, ang galit lang. Okay? Chronic diseases, on the other hand, are those that would develop really slowly. Okay? So meron kang acute disease, tapos hindi ka nagpa-treat, so dire-diretso siya. Okay? Ang subacute naman is a cross between chronic and acute disease. So usually, yung nag-aggravate na acute infection. Okay? Pero hindi pa rin naman siya ganun ka-chronic. Yan, no? Pero medyo matagal na siyang acute infection. So pwede na yung subacute disease. Okay? Ang latent disease, ito yung inactive phase. Pero it doesn't mean hindi siya infectious. Okay? Pwedeng wala lang tayong outward signs and symptoms na nakikita, pero naaang organism. Okay? And then we have local, systemic, and focal infection. So what do you mean by those? Okay? So pag sinabing local infection, ang pathogen is present only in a small area of the body. Say for example, na lang kay nuka, no? Na kay samad, so ma-inflame. Or sakit ng ngipon, so ang ngipon lang may problema. Pag sinabi namang focal, so mga local infections ito na nagrabihan. Okay? So instead na sa balat lang, dahil napabayaan, pwede siyang maging subacute and then it can also affect bones. Okay? Systemic, on the other hand, it involves several vital organs. Okay? So infection throughout the body. Bacteremia is presence of bacteria in blood, and of course, septicemia is presence of bacteria, no? Growing bacteria and their toxins. Okay? So again, toxemia, presence of toxins in blood. Primary infection, this is the acute infection that causes the initial illness. Like say, cough and colds. Okay, that's your primary infection. Secondary infection, these are opportunistic infections that would occur after a primary infection. So example nun, so no primary infection ka, ubusipon. Secondary infection ka, pneumonia na. So usually, pinaka-common na secondary infection is pneumonia. Okay? And subclinical disease, no signs and symptoms. Similar to latent infection. Okay? So ano-ano ba yung mga reservoir, no, ng ating mga infectious agent? So kanina nakadiscuss tayo ng portal of entry, portal of exit. Meron naman tayo ngayong reservoir. So usually, humans are good reservoir for your AIDS, for gonorrhea. Ang animals naman, sa dogs, like may rabies, cats, Lyme disease sa mga ticks, okay? And then some thrive well in non-living things like the soil, like yung botulism, and tetanus. Okay? Agents of botulism and agents of tetanus. Okay? So transmission of disease. O di ba nag-ano talaga tayo, chain of infection. So transmission of disease, syempre, no, pwedeng pinaka-common is direct contact. Okay? Under contact, we have direct, indirect, and droplet. Pag direct, close association with infected host. Okay? Indirect, you spread things by fomites. Okay? Droplet, via airborne droplets. Okay? Pag-atching, pag-ubo, pag-tawa, pag-usap lang. Okay? And then you have yung mga vehicles. No? Vehicles natin yung sa inanimate objects, sa pagkain at tubig, lupa. Okay? So they may transmit organisms. And of course, we have vectors. Now, vectors usually refer to arthropods, mosquitoes, flea, ticks. Di ba naatay ka ng biological vectors, no? So, ang biological vectors kanang tawag nito, the pathogen requires the organism para makumpleto niya yung kanyang um, life cycle, no? Like in the case of malarial parasites and mosquitoes. So mosquitoes would require are needed para makumpleto yung life cycle ng mosquito. Okay? Kasi sa mosquito nangyayari yung sexual life cycle ng malarial parasite. Okay? Tayo, ano lang tayo, no? Yung asexual life cycle. Okay? And then syempre meron tayo nung mechanical vectors, yung mga langaw, 'di ba? Oh, so kinakain, nakadikit sila sa tae, for example. Eh 'di ba mabalahibo yung kamay nila? Hmm. Tapos pagka mamaya mo dumating ka, may dala-dala kang pagkain o naamoy nila. So, tugpa na po dito sa imuhang pagkaon. So, yung galing dun sa tae, naipasa niya dun sa iyong pagkain. Okay? Ayan, gaya niyan. 'Di ba? O, ito si auntie and si uncle, close contact. Okay? Eto namang isa pang uncle, airborne droplets. Kikita niyo yung droplets sa pag-atching. Eto naman sa baba, food. No? And then, ito yung ating vector. Okay? Silangaw. Okay? That ends our topic for the week. Okay? So again, yung ating control of microbial growth, meron tayong physical and chemical. Pag physical, this would include heat, what else? Cold temperature or low temperature, filtration, desiccation, and of course, radiation. Of course, sa chemicals natin, marami tayong iba't ibang pwedeng gamitin, your phenols, no, your phenolics, your halogens, your aldehydes, alcohols, okay, peroxides, no, ang dami pwedeng gamitin. Peracetic acid, benzoyl peroxide, etc. Okay? And of course, yung AST natin, yung factors that are needed, no? Syempre, yung media, dapat either Mueller-Hinton, dapat 4 mm, dapat 7.2 to 7.4 ang pH, okay? Yung incubation mo, dapat 35 degrees Celsius, 16 to 18 hours. Of course, ang ating inoculum, dapat 1.5 times 10 to the 8th sa iyong water, sa iyong yung inoculum size natin. Okay? And then of course, for our mechanisms of pathogenicity, no, yung ating portals of entry, no, yung mga elements ng chain of infection. So, yung portal of entry, portal of exit, modes of transmission. Okay? So, bantayan, no? Pag-aralan ulit kung ano yung mga na-discuss natin. And then if you have any questions, you can just ask me sa GC natin or when we see each other. Okay? So that ends our discussion for today or for this week. Thank you for listening.